This is a special presentation from the Brighton Central School District.
Good evening, everyone. I think we're going to get started, if you don't mind. My name is Kevin McGowan, and welcome to Brighton High School. I'm the superintendent here at Brighton, and my job tonight largely consists of saying hello and then getting out of the way, which I'm pretty good at. On behalf of our district and our board president, Mark Henderson, board members Julian Gilbert, Martha Scaramano, all here tonight, thank you very much for coming. We're very glad that you could be with us to learn more about the opioid crisis from a variety of perspectives and to have an opportunity to ask questions of this very, very sharp panel full of experts in the field. We continue to look for ways to be your partners in prevention here in the district, so look for more events like this to come in the future as we think about ways that we can continue to support your children and the community. Before we begin, I'd like to thank a few people here tonight that helped to make this possible. Dan Goldman, our communications coordinator, Carolyn Rabideau, our director of student support services, Tom Hall, BHS principal, Lance Mitchell, prevention specialist here at Brighton, Rob Thomas, our TCMS principal, Deb Pulley, who is the president of the Brighton PTSA, and Dr. Mendoza, of course, a Brighton parent, but also our county health commissioner, Mark Henderson, our Brighton chief of police, and Bill Maley, our town supervisor, all of whom got together, put their heads together to talk about this evening, how to make this the most effective presentation for our community, again, to bring as many different perspectives as possible, and really focused on supporting children, but supporting the adults in this community as well. So thanks for all of them. And on the practical side, thanks to Christopher Schneider, Bill Moyer, and Dr. Mike Leaner for helping us pull the practical applications together. Thanks to all of you for your help. I'd also like to thank a few other people in attendance tonight. Robin Wilt, Chris Werner, Brighton Town board members, thank you very much for coming. Louise Novros, recently retired town board member, thrilled to see you here tonight as well. So just a quick introduction of the people seated to my right, our panel for this evening. Of course, Dr. Mendoza, Monroe County Commissioner of Public Health. On the far end, Mark Henderson, our Brighton Police Chief. Robert Zerby, Monroe County Chief Medical Investigator for the Office of the Medical Examiner. Lance Mitchell, who is the Brighton School District, as I mentioned, Prevention Specialist. Lori Drescher, a Certified Family Recovery Coach, Advocate, and Trainer. If you could join me in welcoming them tonight. So before we launch into Dr. Mendoza's presentation and the panel, I'd like to ask Brighton Town Supervisor and a great advocate for our community and our schools, Mr. Bill Maley, to say a few words.
Thank you, Kevin. Great to see so many people here tonight. Before we start, I do want to acknowledge, I know so many people in Brighton and throughout the community assisted in the search for Trayvon Rowe these past few days, and I know there's great sorrow throughout the community at Trayvon's loss. So in keeping with the memorial ceremony that's going on downtown tonight, if we could begin just with a moment of silence in memory of Trayvon and his family. Thank you. I know Kevin mentioned, but I do again want to note Councilmember Chris Werner and Robin Wilt are here. I believe Councilmember Jim Vogel is coming as well, but I may be missing him out there in the dark. But you know, I'm so pleased that the town, the school district, and the county were able to come together to address tonight so that we can all learn together more about this crisis, this epidemic of opioid use. The town and the school district work together on an ongoing basis on so many issues, but probably none more important than this. So Kevin, I'm truly grateful for all the work that you and everyone from the district are doing. Dr. Mendoza, Brighton resident, the work that the county health department is doing. So this is something, it's an important issue, it's one we will address together, and it's one that tonight we'll learn together. So I'm glad to be here, and again, Kevin, thank you very much for the role of the school district.
Thank you, Bill. And finally, to welcome you and introduce our presentation this evening, please join me in welcoming our Deputy County Executive, Tom Van Strijdonk.
Good evening. He was practicing that Van Stridon part. You got it right, Bill. Thank you. Thank you, Bill and Kevin, for joining with the county and other concerned people to come here tonight to talk about one of the more challenging health crises that our nation has faced and that continues to threaten our children, our mothers, our fathers, everyone in our community. Heroin and opioids have taken a heartbreaking toll in every corner of Monroe County. The rising tides of opioid addiction in the United States are a massive public health problem, not just for individuals to bear the burden. Our medical examiner's office has determined that over 200 deaths across our 10-county region were directly attributable to the use of heroin, opioids, fentanyl, or other related substances in 2016 alone. 2017 promises to top that record, if a record is something that we can refer to. We are here today because the sad truth is that everybody knows someone who has been impacted by heroin or opioid addiction. It could be the student athlete who was prescribed an opioid for a sports injury and who ends up getting hooked. It could be the son or daughter who finds an expired prescription in the cabinet of their mother or father or their grandparents, only to end up transitioning to other harder drugs. Or it could be any number of everyday families here who have been devastated by this deadly crisis. I've been asked to introduce our Commissioner of Health, Dr. Mendoza. You can see from, oh, you took the slide down. You can see he has two titles. Commissioner of Public Health, now I got it right. And the Associate Professor of Department of Family Medicine, which is where we recruited Dr. Mendoza from. What seems to him to be eternity ago, I'm sure, but it was a few months ago when we convinced him to part-time practice medicine and to become our Commissioner of Public Health. I am sure that when Dr. Mendoza agreed to take this position, he was really not aware of what he was going to get himself into. His kids, however, enjoy the fact that they can call him the commish and that he has special privileges. So Dr. Mendoza has been asked by our county exec, Cheryl Denolfo, to convene a brand new advisory panel on opioids, where some of our area's foremost medical experts from the emergency departments of both of our major medical providers will share their opinions and suggestions on how we can better improve the system of treatment in our community. The combined expertise of these medical professionals, led by Dr. Mendoza, is staggering, and we intend to harness their collective knowledge and experience to improve our community's response to this crisis. And our improvement of our community response is necessary to better address the issues that are seen every day in our emergency rooms. To have representatives from some of the largest healthcare institutions in our region serving on the same panel for the same cause is going to be an incredible asset to this effort. Many of our outreach efforts incorporate training on the use of Narcan, a safe and effective emergency nasal spray that can be easily administered to stop an opioid overdose. In many cases, Narcan can mean the difference between life and death when seconds are critical. There will be plenty of opportunities for residents to participate in the future as well. These seminars on the use of Narcan will typically be held under Dr. Mendoza's watch at the Health Department on the fourth Wednesday of every month, with both morning and evening sessions. Dr. Mendoza will get into the specifics with the panel discussion that follows. As the old saying goes, an ounce of prevention is worth a pound of cure, and we hope tonight will be the ounce of prevention that will help all of us step forward and help to take care of the people who find themselves addicted to these terrible drugs. And so without further ado, I'd like to introduce Dr. Mendoza.
If you notice on each side of the auditorium, there's a music stand with index cards and pencils. We would encourage you, if you have any questions along the way, the Q&A will be based on those cards. So simply write your question on the card, leave it on that tray, and then they'll be collected towards the end so that a good discussion can be facilitated after all the presentations. Thanks, everyone.
Thank you, Kevin. Well, thank you all for being here tonight. My name is Mike Mendoza. I'm the Commissioner of Public Health for Monroe County. I'm a family physician. But honestly, what is probably the most important credential that I can share with you all tonight is that I'm a Brighton parent. Just like all of you, I'm here hoping that we can continue this conversation, learn a little bit from one another, and truly demonstrate the all-hands-on-deck approach that we will need in order to get our way through this crisis. As I've gone to speak to probably a dozen schools now, the conversations are different, they're difficult. If this is a topic that is uncomfortable for you, you're not alone. But I think it's important for us to confront that discomfort because this is a topic that we need to talk about. There's a lot of stigma and misunderstanding around this, and honestly that is currently an enemy to us, and we've got to do everything we can as a community to break that down. So this is our agenda for the next 15 to 20 minutes. I want to talk about addiction, and I really want to emphasize that addiction is an illness. It is an illness that people don't just wake up one day and choose. I want to talk about overdose as a separate but related problem to addiction. And talk a little bit about where we are right now with regard to the epidemic that you've heard of and say more about what that means. Talk a little bit about what we're doing at the county level, and then finally end our presentation tonight with some homework. It wouldn't be a school night if it wasn't for some homework. So I'm going to give you some homework to take home for you all to do both as individuals and with your families. So, do we have any gardeners in the group? What is this? Poppy. I had somebody from Hilton give me the genus and species of this. So, I don't know if anybody here can do that too. I put this up here because this is the origin of opium. Opium has been around as a medicinal substance since the year 3400 BC. It's natural. It has, as we all know, very important pain control properties. It's been used for all those years as a valid method of analgesia. And as we know, it has become, of late, a substance of abuse. I put this up there to underscore the reality that just because it's natural doesn't mean it's necessarily good for you. And any natural compound, if used in the inappropriate way as opioids have been, can become addictive, and they can become habit-forming, and they are a drug. And so I put that up there just to put that as the background, because there's a lot of misunderstanding about drugs. Opioids are part of the body. We all have them in our body right now. They are a natural part of our physiology. It's what controls pain and a host of other functions in our body. And we need it. And we as physicians use the system to provide medical benefit. But when things go awry is when addiction can happen, and so that's what we want to talk about tonight. So first of all, I want to underscore that addiction is a disease. It is an illness. It's not unlike hypertension or diabetes or heart failure or any of the other medical illnesses that I care for in my office. To underscore the biologic nature of addiction, what you see before you is a PET scan of a human brain. And the yellow portions are just sort of general metabolic activity. On the far left is a picture of an individual who is not currently using drug of any kind. The middle picture is a picture of an individual's brain who has an addiction to cocaine. And this picture is actually the same no matter what the substance is. So this isn't a picture of cocaine. This is a picture of addiction. And this is what the brain looks like after 10 days not using cocaine. There's still lingering effects of that addiction, even though the cocaine has left that individual's system. The final picture is a picture of an individual addicted to cocaine who's not used for 100 days, so over 3 months clean. And as you can see, the brain activity has not returned. This is not somebody's choice. This is not something that you can just wake up one day and say, I'm going to get better today. The other point I want to point out here is that this underscores the importance of sustained support through recovery. Because if somebody can manage to get through 10 days, they still have a long way to go before they can kick that addiction. And as many of you know, you really can't cure addiction. We don't think of addiction as something that's 100% curable, much in the same way as I don't think as hypertension as being curable. But we do think it's manageable. And what we want to do is help people to achieve a lifetime of sustained recovery from addiction. And so that is the goal for this illness. But this is a disease. This is not unlike any other disease that we take care of in the office. And about half of our risk for having addiction is genetic. People with a genetic predisposition to having addiction have no choice about that. This is something you inherit at birth. And there's no way to know if you're one of those individuals who has that predisposition. You may find out later in life because you notice it in some fashion, but the vast majority of people who struggle through addiction have no way of knowing if they're in that 50% of people who are predisposed to having addiction. And we think the other half of the risk for having an addiction is environmental. It's the environment in which we grow and live, in the schools, which is why it's so important that you all are here tonight, because you all have a direct role in helping to provide for a supportive environment for our schools and for our students. So early exposure is probably one of the most important exposures that we can prevent to help decrease the risk of later addiction among our kids and young adults. And so along that line, I want to show data reported by youth here in Monroe County. These are high school students, self-reported data from 2017, last year. We collect these data every other year through the Youth Risk Behavior Survey. It's a national survey designed by the CDC. We do that here in the Health Department every other year. The far left here shows the percent of 9th, 10th, 11th, and 12th graders who self-report the use of cigarettes, e-cigarettes, alcohol, binge drinking, and marijuana in the last month. And this is across the entire community here in Monroe County. We didn't get enough people surveyed here to make any comparisons from school to school, but the point is that there is every school district represented in these data, and no school district is immune. So when you think, our school might in some way be different, we're not. And so as you can see, from anywhere from 10% to upwards of 42% of our young adults are at risk. I put this up here not to say that they have an addiction problem or to say, but merely to say that these individuals are at risk potentially for addiction down the road. On the far right are 3 sets of bars that show, self-reported again, heroin use, prescription drug use to get high, and over-the-counter drug use to get high ever. And as you can see, these numbers are not insignificant. And so I would say that these individuals are definitely on the path toward addiction. And so I put these data up here not to scare anybody, just simply to show the data. These are facts. This is the reality that we need to accept here in Monroe County. And so I don't need to tell you about the human toll addiction has taken. The stories are virtually daily in the papers these days. And as was mentioned earlier, this is about people, this is about families, this is about people that we know and love. And as hard as it is to get over the misconception about addiction, I think we need to view it, again, as a disease and support people and not judge people for having this illness. We wouldn't think of judging somebody who has cancer or high blood pressure. In the same fashion, we shouldn't be judging people who struggle through addiction. The economic numbers are staggering. Annually, $120 billion in lost productivity due to addiction. About half of that due to addiction to prescription drugs. And then when you talk about early exposures, the sad truth is that 1 in 10 children in the United States is living with an adult who struggles through addiction. And the vast majority of these individuals, these kids, are under the age of 5. So we have major opportunities both in this community as well as across the country. And so I added this slide a couple weeks ago because I want to underscore that addiction has been around for a long time. And a lot of people say, well, what's going on? We've had addiction, I've known people with addiction for a long time. As you can see here, the numbers have been generally stable for the better part of the last 15 years. But what you can see here in 2014 is that there's definitely an uptick in addiction. And I won't read the details here to you, but illicit drugs is the square, and then marijuana is the circle. Prescription drug use is in the triangle here, and this has been relatively stable. So, what we're seeing here is that addiction is a little bit more common. It's definitely taking a turn up. The 15 and 16 numbers haven't been released, but every indication is that they've gone up as well. But what I want to point out is that the increase in addiction has not been nearly as rapid as the increase in death from overdose, and so we'll get into that next. So think of addiction as a chronic illness, and think of overdose as an acute exacerbation of a chronic illness. So not unlike asthma. If you know or if you have asthma, it's a chronic illness, but we don't, generally get sick from asthma unless we have an asthma flare-up. And in many ways, overdose is like an addiction flare-up, except it's not a perfect analogy because a lot of people who have an overdose, unfortunately, didn't have an addiction problem. And so we need to look at these problems somewhat differently. They're related, but they're to some degree separate as well. So how do we get here? And this is a common question that I get, and my answer is always first to say that it's complicated. As a physician, I will own the beginning part of this. We as a medical community in the early 2000s, we were, I would use the word complicit, in prescribing a whole host of opioid medications to our patients. And one of the main reasons for that, and if you've ever been to a doctor in the last 20 years, you've been asked the question, are you having any pain today? And you're expected to give a number from 0 to 10, and some bodies even called it a vital sign. You stop and think of what a vital sign means. You have a heart rate, you have a pulse, you have a respiratory rate. Those are vital signs. Those are signs you need to have to be alive. If you think about it, you don't need to have pain to be alive, and yet that was the mentality that was driven into physicians like me and many, many others. And so that was the dynamic that was set up for the following 10 years. Pain became the enemy. Our job as physicians was to eradicate pain with everything possible. And the industry got involved and produced stronger and stronger pain medications. And so when you add it all up, by the year 2010, there were enough painkillers prescribed in the United States to medicate every US adult around the clock for a month. That's 2010. That's not that long ago. And thankfully, we've made some progress with regard to overprescription. Here in Monroe County, we're one of a few counties in the state where the prescription rate per capita for opioids has started to go down, which is a great sign. We have a long way to go. But unfortunately, as that has happened, we still need to take care of people with addiction, and we're not quite there yet. And so unfortunately, as we take away the supply of prescription opioids, people are substituting that with street opioids, heroin, fentanyl, things that you get on the streets. And that is why we have the epidemic of overdose-related death now. So just to underscore the point, these are from 2015. Drug overdose deaths in the United States now eclipse the peak of the HIV/AIDS epidemic back in the 90s. Higher than car crashes in the same year, higher than gun deaths, higher than gun homicides. This is overdose death. You can see here the red bars are drug-induced overdose fatalities, very clearly on the rise, as motor vehicle accidents somewhat on the decline, and then firearm-related mortalities growing but not nearly at the same rate as overdose mortality. This picture kind of underscores what I was saying earlier. As we've decreased the supply of prescription opioids on the streets, people are turning to different opioids. And so, green is any opioid. These are overdose-related deaths in the United States from 2000 to 2015. As you can see here in 2010, this is roughly when a lot of the regulations to help to decrease overprescription went into place. And you can see a pretty marked rise in heroin at roughly the same time. We don't have any great science to prove that this is causation, but there's definitely an association between these two. And then more recently, we've started to see the spike in fentanyl and tramadol-related mortality. And by fentanyl and tramadol, tramadol is prescribed. The fentanyl here that is the cause of most deaths is not the prescription fentanyl. We can prescribe fentanyl for pain. It's generally as a patch. But the fentanyl that's killing people more recently is not prescription fentanyl, and we'll get into that. And this is, as a public health professional, one of the worst case scenarios that I can imagine. So life expectancy in the United States, how long we live in the US, has gone down for 2 consecutive years. It has not done that in our lifetime, ever, in 2 consecutive years. The only time it went down at all was in the 90s, here in 93, due to the HIV/AIDS epidemic. So this is 2 years in a row. This is unprecedented in our generation. And this, we all believe, is due to the opioid epidemic. I put this up here, and these data are as of 2015. But by every measure, this is an epidemic that obeys no boundaries. This impacts males, females, young and old. I don't think I showed this slide with age groups on here, but it's every age demographic. Here in Monroe County, it's every ethnicity. And so this isn't something that we can say just affects the city or the suburb. It's across every known demographic that we can describe. And it's right here in Brighton as well. I put this slide up. If this was the US Olympic gold medal count, I'd be proud of this. But unfortunately, it's not. This is the standard daily opioid dose per 1 million people. The United States is sadly way at the top, well ahead of Canada, Germany, and others. And this is using actual prescription data. So this is something that, and this is, I think, of 2015. So, this is, as much as we're doing better, we still have a long way to go. And in spite of all the pain medications we're prescribing, we're actually not really doing any better with managing pain. These data are as of 2010, but as you can see here, the proportion of Americans who are reporting that their pain is in better control is not going down. In fact, in some respects, it's going up. So we're not doing a better job of controlling pain for even all of the pain medications that we do prescribe. And so this is a somewhat complicated slide, but let me go through it with you. Along the bottom here are all the counties in New York State. And these are using data from 2017 released by the CDC just last January, or July. The orange line is the amount of prescription opioids per capita in that county. Okay, so as you can see here, if you can read this, Sullivan County has the highest prescription rate, and down here it's Kings County with the lowest prescription rate of opioids per capita. And the blue bar is overdose-related death per 100,000. My point here is that there's really no good correlation anymore between prescription opioid rate and mortality. And my interpretation of this is that the overdose-related mortality is no longer from prescription opioids. Prescription opioids were a major part of getting us here. It created a whole host of dependence and did not help the addiction epidemic. But what we are dealing with right now is an epidemic of overdose from non-prescription drugs. And 80% of the overdoses in Monroe County last year involved fentanyl, and that was not prescription fentanyl, that was street fentanyl. And so the data were reported earlier, 169 deaths in 2016. We don't have the final data from 2017 yet, but by every account it's going to be higher than in 2016. And so why do we focus on overdose? Well, I focus on overdose because I believe it's preventable. Okay, we have a long way to go to help people through addiction. The services in our community for addiction are growing and clearly not enough. But we can't wait until those addiction services are 100% before we tackle this problem. Because we've got to get our hands around the overdose problem first. Because as you've seen in the papers, just the first 2 months of the year, we've had a number of overdoses in our community. We've got to get our hands around this. And I focus on this because I believe it's preventable, and we'll talk a little bit about that. And so I focused on the emergency departments and on hospitals because I believe, as a physician, that we have a captive audience when we take care of people who have an overdose who come to our hospital. And by most measures, everybody who has an overdose in this community will find their way to a hospital at some point. The number of visits to ERs has gone up threefold since 2005 in our region. And we know that anybody who comes to the emergency department, these are national data now, anybody who comes to the emergency department with an overdose has a 41% chance of coming back to the ER within 3 months for any reason. So these are people who are well known to our emergency department colleagues. 31% of them will come back for a substance-related reason. 12% will come back for another overdose. and 9% of them will come back with another opioid overdose. And so one of my efforts in both of our ERs is to try to expand access to Narcan for anybody who comes in with an overdose, because we've got a good chance of them coming back for the same thing. And so we need to work on the known risk factors for overdose-related death. For all the things that we do for addiction, we also have to focus on those things that predict mortality from an opioid overdose. The number one is mixing multiple substances. This underscores the fact that we're not just talking about prescription opioids anymore. We're talking about street opioids, fentanyl, heroin, all those things on the street that frankly our users don't even know what they're getting. Using alone is a risk factor for dying. This just underscores the fact that if you overdose and there's nobody there to help you, you're not likely to survive. The third point here, loss of tolerance following abstinence. What this means is that even if we can get somebody detoxed and into recovery, we can't stop there. We've got to continue them on that path of recovery. Because if they relapse, they actually have a higher chance of dying, because the same amount of drug that they used before that was fine is now going to kill them. And so we need to help our patients through long-term recovery, not just short-term recovery. And then obviously other mental illnesses, depression, other things can also increase your chance of dying. And so I'm proud to say that here in Monroe County, we've got what I think is one of the best plans that I've seen. When I talk to my colleagues around the country, they look to our plan as a model in many ways for what a county can do to get their hands around the opioid crisis. This isn't to say that this is everything. This isn't to say that, now that we have the plan in place that we can just sort of sit back and watch. We have our work cut out for ourselves, but I think this is one of the more robust plans I've seen in the country. And like I said, we have a lot of work ahead of us. And so I want to close by sharing with you some suggestions for things that you can do. First of all, being here, raising your awareness, doing what you can to decrease the stigma around addiction is critical. If you can share this conversation with 2 people who are not here tonight, I think that would go a long way toward decreasing the stigma that we see around addiction. Second of all, go home, look in your medicine cabinets, and find medications that you're no longer using. And they don't just have to be opioids, but we want you to focus on that. Whether it's high blood pressure medicines, Lipitor, whatever. If you're not using it, it's just a liability. And when it comes to opioids, we know it's definitely a liability because it's a time bomb. If somebody happens to take it by accident and take too much, they could be at risk for an overdose. We also know that opioids in medicine cabinets are the source of criminal activity. Some of the people who are in the market for opioids follow the medical motors vans around, and they look to see where people get out with crutches. If you think about it, people who are on crutches are much more likely to have an opioid in their medicine cabinet, and they become the target of crime. Here in the county, I want to encourage you to all learn how to use Narcan. It looks like this. Maybe one of the few people who carries it everywhere I go, but I want you to be one of them too. We are providing training in the health department every month, 4th Wednesday, both morning and evening. And you can get this at any pharmacy. Here in the county, you don't need a prescription. We have a standing prescription that we've authorized through the health department that allows you to walk into any pharmacy and get the Narcan. If you have a copay, up to $40, will be reimbursed to the pharmacy so that you don't have to pay it. So generally speaking, the only people that have to pay anything for their Narcan is anybody with a high deductible plan. So I've tried this a couple of times. I've walked out with Narcan, no cost to me. If you are in the position of struggling through addiction, get help. We are here as a healthcare community, not just physicians, but everybody else. We want to help you. We want to help you to get help. We want you to help your loved ones. And most importantly, understand that addiction is a disease. It's an illness that we need to support people through with the same love and compassion and support that we do every other illness. And then remember that overdose is preventable. Thank you very much.
So is Kevin coming back up? No. So I've been asked to define whether we have a problem here in Brighton or not. And as Dr. Mendoza said, this is just not an urban problem or a suburban problem, it's a region problem. And I can talk to you firsthand about some of the issues we've experienced here in the community. I went to a call one morning where a person was found deceased by her 10-year-old son, and that person had overdosed on, it was a mix of heroin and fentanyl. And from that experience, the response that we took is a response that law enforcement has taken. We're not going to be able to arrest our way out of this epidemic. Would you agree with that statement, Doctor? But what we did was, you just didn't dismiss it as an overdose death. We looked at how the person came into the possession of the heroin. We were able to secure data, call in an investigative team, and we were able to find a source. We were not able to find a nexus to the original sale. Some of my colleagues were able to do that and charged for homicide. In our particular case, we were not able to do that, but what we were able to do was identify a street-level dealer, which led to a distributor, and through that distributor, we were able to secure search warrants. The execution of the warrants, not only we were able to secure heroin, we were also able to secure firearms. So in law enforcement, we're looking at data. We're looking at data in a real-time perspective. Information that we were able to, and evidence that we were able to seize in the situation in Brighton, we shared with our colleagues. We're part of a regional narcotics enforcement task force. Sheriff Baxter talked about starting up a command post that deals with data on a daily basis. Anytime there's a call for an overdose anywhere in Monroe County, that data is transmitted back to the command post. We are a participant in Granite. We also share our data through the Monroe County Crime Analysis Center. Knowledge is power. If we're seeing a particular type of product in Brighton, and it's a pretty good likelihood that my colleagues in other parts of the county as well as the city are experiencing the same thing. So our efforts are focused. We're collectively working together. And Chief Zerby is going to talk about data as it pertains to data and causality of death. We're able to take a data approach and put it into a collection, and through that collection we can use this real-time data to either stand up more resources around the county. From a Brighton perspective, all of our officers carry naloxone or Narcan. We're one of the first agencies in the area. Along with the RPD, we received a grant from the Attorney General. Everyone carries Narcan. I was told early on, well, you really don't need it in Brighton. You're not going to use it because the profile of a suburban drug user was somebody that used alone and used in the basement of their home. And by the time Narcan, you responded to the scene, it would be too late. That didn't last very long. It was about 2 weeks before we had a situation where somebody was driving in a car trying to get help for somebody. They pulled over to do CPR, and our officers deployed Narcan. Since that, we have been called to homes. We have deployed Narcan. We've deployed Narcan to the same person on multiple occasions. So we'll continue to carry naloxone as long as hopefully this epidemic has, it'll run its course and run out. But if it doesn't, we'll carry naloxone. Dr. Mendoza talked about turning in unwanted pharmaceuticals. We have a very aggressive pharmaceutical collection campaign. It started back in 2009. We participated in the drug enforcement of the DEA pharmaceutical take-back. There's the last Saturday of April. You can drive into the public safety side of the town hall. You don't even have to get out of your car. You can just give us a bag or whatever. We'll take it in and we'll destroy it. We destroy it through incineration in Niagara County. We also offer the services of a pharmaceutical collection box at the town hall. You don't have to be a town resident. You can just walk in our front doors. The lobby is open 8 a.m. to 6 p.m. You can just come in. It looks very similar to a mailbox. It's a secure collection point. No questions asked. We'll take the pharmaceuticals in. And then I will extend the same offer that a number of my chief colleagues are offering. If you can't come to Brighton, you can't make it to our collection take-back day, we will come and take it from you. Just give us a call my office, send me an email, we'll coordinate whether you live in Brighton, wherever. will come out and securely take that prescription that's no longer in use. Another aspect is from a law enforcement standpoint, we're partnering with addiction services, Churches Combating Addiction. I'm my 33rd year in law enforcement. I can't say that we've ever done that before, but we're agreeing that this is a multi-discipline approach. We're not going to be able to arrest our way out of it. We've got to work collectively and collaboratively. Chief Zerby.
Thank you. Good evening, and thank you for the invitation to participate. And a bigger thank you to you for actually coming, showing that there's an interest and recognizing that there is in fact a problem. As it relates to statistical numbers, the numbers that come out of our office are essentially confirmation numbers of what the police agencies are seeing at the scene. The initial data that they're focusing their primary attack on, particularly as it relates to isolating dealers, is if there's drug paraphernalia at a scene, and then if a person is dead at a scene. They're combining the two and assuming it's a drug-related death. Excuse me, the medical examiner's office is more of a scientific facility, and while everything might give the appearance of a drug overdose, we won't release drug overdose information until it's finalized. As you can see by the numbers, as you can see by the increase, they caught us completely off guard. It's been business as usual as the ME's office for at least the last 28 years that I've been there, and then all of a sudden there was this, highly tox-related causes of death. Our current turnaround time is roughly 7 to 8 months before we actually have final information. And as Dr. Mendoza alluded to, what we're seeing isn't necessarily running a drug screen and seeing, look, there's heroin. It's, look, there's heroin, look, there's fentanyl, look, there's other substances that are associated, opioids, and analogs of the different things that we're seeing. And putting this all together and trying to figure out the lethality of it is just profoundly complex, and hence the backlog. What I will do is speak anecdotally. If you're a parent, pay attention. Pay attention to what's going on around you. Pay attention to your kids. This in the old days, if you're old like me and you look around, you remember that when heroin was on the street, there was a certain look to the heroin addict, the so-called junkie. It was some middle-aged guy, and he had long, scraggly hair, and he was just kind of hanging out in corners, and he would get his high, and that was kind of the extent of it. They weren't dying because it was heroin, and they knew what they were supposed to take and not take, and that's just kind of how it went. That's not even close to the model anymore. It's everybody. So pay close attention to what's happening to your children, to your friends, and it starts off small. And what I'm hearing from families, you're at the scene where their children or a spouse or whatever has passed, is, you know, I saw this coming. I should have known this is here. They've recognized the signs, but there's this obscure stigma that we kind of have to stomp out. Okay, so you're an addict, big deal. Then you fix it. It's like, okay, you're a diabetic, big deal. Don't eat cake. I mean, this is dealt with on a day-to-day basis, yet somehow addiction has this, oh my gosh, it's awful. And we'll get over it. I'm sure we'll get over it. It's very similar to the whole HIV/AIDS thing when that came out. That was just, there was a huge stigma with that. The amount of legislation that's on the books for that particular disease, no other communicable disease had that level of legislation protecting the confidentiality of it because of the stigma. And we stomped that, so we can stomp this as well. Gateway drugs, the wonder of gateway drugs, and I don't want to steal your thunder, everything is. Don't let anyone tell you otherwise. If you smell the smell of marijuana in your basement, you know, don't, oh, it's just marijuana, no big deal. It's a huge deal. What happens is your community, 50% of the likelihood you will become an addicted person, potentially to an overdose state, is that you have to receive the substance, and you hang out with people that you can get the substance from. And if there's marijuana with a dealer, chances are good there's no real exclusive marijuana dealer. He'll have other stuff that you can try, and they'll offer it to you. They'll offer it to you for free because the best thing for them as a business person is to get you hooked. Think a legitimate business. How many times do you get a free month of something? Why do they give you a free month of something? Because you're going to get hooked. Because just in general, people are addicted to things. Getting addicted to cable TV, no big deal. Getting addicted to opioids, that's a real big deal. Ask the questions. If you smell the smell, if you see the sights, if you see changes in behavior, again, I won't steal a thunder to my left, but pay really close attention to what's going on around you. If we're at the scene and you're telling me all the things you should have or could have done, it's entirely too late. Thank you.
Didn't steal too much of the thunder. I wanted to just acknowledge the agencies that you're in outside today as you leave tonight. There's some wonderful people that are here to give all kinds of background of tools or services that you can provide not only for your community, for your family, or for other ones that you know, please stop by the tables outside. And I'm just really happy that they came to support us tonight. They really believed in it, and it was just great to get the phone calls as we were putting the whole evening together. One of the questions that Dr. Mendoza shared again, and I want to highlight again, or he said, what can you do in your sphere of influence? Moms, dads, grandpas, aunts, and uncles that are here. I kind of want to back up a little bit more into maybe even the day-to-day for us, and being middle school or high school counselors and social workers. There's steps way before a lot of the things that are going here. And what I mean by some of the steps and some of the things there's vaping, e-cigarettes that Dr. Mendoza talked about a little bit, and also with marijuana, cannabis, weed, whatever you want, whatever your language, whatever you call it. Gateways, yes, those are steps. They desensitize many of our students, children, before making those, having those cues of saying that, you know what, this isn't so good, that if I move to the next step of using something much harder. Now, this is a difficult ground for many, because I'll get different calls from folks just within the school district here. Like, look, at my kid's not using opioids. What is the big deal? They vaped a little bit. Well, with the vaping, and I really don't have the time to get into it tonight, but it's stronger than the cigarette that they're maybe trying to prevent. You know, it's 12 milligrams that are in a cigarette, in a Juul, something the size of a thumb drive, and the kids are vaping 6 to 7 times a day, and it's 47 milligrams of nicotine. So that nicotine starts the whole thing of addiction that's there. It's a want, it's desire. What's the next step from there? They're going to be, again, desensitized. They're going to be open to other things that are going to be possibly offered to them. Well, that person's not really going through a difficult time. They're not an opioid addict or abusing or something like that. Maybe I can, take a risk of using it. It's not a real big deal. It is a big deal. And also, there's a feeling that, well, again, if I'm using weed, marijuana there, it's not so bad. Well, yes, it is. Now, this is like comparing the marijuana that's today. It's like hockey mom's minivan to a Lexus car right now. Early on, maybe in the 80s or 90s, and I'm sure maybe the doctor can correct on some of the figures here, the active ingredient of THC that's in marijuana was around maybe 3 to 4% of the active what? Some of the teens, people that are smoking, young adults, whatever, it's moved way past that. Right now, the active ingredient is around 24% of a teen getting high. 24%. And I'm not even talking about another usage of dabs, and that's anywhere between 75 to 90% with THC count. This is huge bump. The desire, the addiction piece is gone up so much that it does make them susceptible to using something that's much more at risk, and leading to some of the things that were just been shared by Dr. Mendoza and Mark. So that's what I'd like for you in your own sphere to go back to your kitchen table, to your mosque, to your temple, to the ice, the softball field, cheerleading squad, wherever it is, your grandchildren, whomever it is, and don't get into the conversation, well, this is okay because it's not so bad. Well, it's got great smelling in those vapes that are being used. I mean, some of the recent research that you've heard just this weekend of how many carcinogens are in there. It's like, with all the different flavors that are there, I encourage you to really can't get into it now, but it's damaging. And us giving the okay that this is okay, but this isn't, that's not where we want to be. We really want to take a look at and be active in having that conversation. If you don't know, I encourage you tonight, the folks that are outside, to have those conversations, to get more information yourself, or contact myself or anyone that's here on this panel. And another word I just want to leave you with tonight is networking. And I mean active networking. And what I mean by that is that knowing where your son or daughter or nephew or whoever maybe you're in charge of over the weekend, and not making the assumption, well, I've known that child since they've been Council Rock. That's my niece, and they're just hanging out what they're doing in the basement or whatever there is. Actively find out what's happening there. Maybe a cold call. Give you an example of a colleague that shared with me. Her daughter called her up and shared that, look, Mom, don't want to come home right now. Denise, just broke up with John, and she's going through a tough time, and some of us girls are just going to support and love on her. He's such a jerk, but, I'm going to be here tonight. Is it okay? And my colleague said, okay, that's great. That's wonderful. And do you need anything from me? No, she just needs a love, and we're just kind of like hanging out, and I'm going to be home a little bit later. I'll give you a call. And so the colleague hung up the phone and then called her back. Are you sure you don't need anything there tonight? No, I don't need anything. And we're just here, and she's just not doing really well. Mom, I really got to get going. Really? Then why are you sitting on Bobby's lap on the porch? And she goes, what are you talking about? I'm in the driveway watching you right now. That's what I mean by active networking. If it means that you come by the house and always have someone in your community's home, say, can I bring by some wings or some pizza or something? Because it seems like they're at your house quite a bit on these times. I just want to drop it off and see what's happening. You've been such a great support. My son loves going over there. I'm not telling you really got to snoop on your kid, but I'm telling you got to snoop on your kid. Okay, you got to that's what I mean by actively just checking some things out. It could be great, it could be fine, but at least it's sending the message that I care about you, and that I'm just not going to be on autopilot here. So those are, if any takeaway from tonight, it's just looking again that there are some steps that are before we get into some of the harder things and behavior. And Lori will talk about that and now about just the behaviors that are there.
Thanks, Lance. My name is Lori Drescher, and I am a family member affected by the 10-year struggle that my son has had with opioid addiction. In 2014, I got a text from my son that he was about to attempt suicide. And my son didn't really want to kill himself. He really wanted to end the horror that he had been living with. Fortunately, he didn't kill himself. We were able to get him to treatment in Pennsylvania because there was nowhere here to take him. And while he's had a bit of a roller coaster ride in his own recovery, I'm very grateful to say that he's in recovery today. I have since become a certified addiction recovery coach. I have a private practice as a family recovery coach so that I can try to help families avoid some of the missteps that I made. I can help educate them and help them understand that despite many of the well-intended messages that you've received, you can be a very powerful force in your child or your loved one's recovery. I also work with individuals who are seeking recovery. I have a training business to train people to become recovery coaches and peer advocates. My partner is here tonight. We believe that the growing movement of peer recovery coaches is filling a huge gap out in our community to help people who are getting into treatment but that need help to sustain their recovery. Recovery doesn't happen in treatment. Treatment is an acute solution for the worst part of treating the disease. But recovery starts when people go back into their communities. And we have a huge gap in our community and across the board in terms of recovery supports. It struck me that when we first started this evening, we started with a moment of silence for Trayvon, and that was beautiful. But what struck me is if we took a moment of silence for the individuals who have passed away since the beginning of this year, that's January and February alone, we would have had to sit here for 30 minutes. 176 overdoses, 30 fatalities. We don't have time for those moments of silence. But we need to begin addressing this as a community. And I applaud you all for coming out here tonight. I don't know where you are on the continuum in your lives and in your families. But I will say this. Despite the bleak picture, and we presented a pretty bleak picture up here, I think. Despite the bleak picture that was presented, there is hope. There are 23 million people living out there in our country alone in active addiction. There is the same number living out there in active recovery. We don't tend to shed a light on recovery, but we need to. Oftentimes when we see things on the news, we're presenting the most dire information, we're using the most dire images, and we need to begin having the conversation about recovery. And we need people to get involved. We took a busload, 50 people from Rochester to Albany on Tuesday last week to plead with our legislators for more funding for prevention, for treatment, and for recovery. The OASIS budget is the lowest funded government budget at about $615 million, as compared to mental health and development of disabilities, which is $8 billion. And that's one of the more lowly funded organizations as well. We need more, and we need people to call their legislators to ask for more funding. We need to do a lot more than provide Narcan. Narcan saves lives, but by the time you need the Narcan, you need a whole lot of other supports. And I firmly believe that when our loved ones present themselves at the hospital, where we've just heard so many of them show up, that we need to do more than provide them with Narcan. We need to provide them with medication assistance. We need to provide them with a peer recovery support person, with services, and most importantly, with compassion. We talked about the AIDS epidemic. In the worst year of the AIDS epidemic, we lost 46,000 lives. Last year, we lost 67,000 lives to the opioid addiction epidemic. We need to do more. For family members, a few things. One is to know that you can learn to be effective. You can learn how to communicate effectively. You can learn to look at how you are helping and whether or not your helping is effective. If you have a loved one who may be suffering from substance use disorder. Speaking of substance use disorder, we need to think about the language that we're using. We need to use more medically correct and recovery-oriented language. Calling our loved ones addicts isn't helpful. We don't call other people by their disease. Let's use the correct terminology. It is opioid use disorder, or substance use disorder, or alcohol use disorder. Instead of talking about people and their clean time, let's talk about their test results. What is the opposite of clean? It's dirty. Let's not refer to our loved ones as clean or dirty. It's disrespectful. Let's stop calling it abuse and abuser. It is use. It is misuse. Let's stop talking about rock bottom, because it is a misnomer that people have to reach whatever rock bottom is. People need to find a point of motivation to change, and they do every single day. As family members, we need to take care of ourselves. We use a disproportionate amount of healthcare services as family members living with somebody in active addiction. We become just as sick. We need to take care of ourselves. And I encourage you to get involved. We have a Greater Monroe Recovery Community Organization. You can look it up on Facebook. There are many ways to get involved. Our community has everything it needs to deal with this epidemic if everyone chooses to get involved. We have some handouts on our table, some things for parents on helping, effective helping, and on some guiding principles for families who are in recovery, like me, and we encourage you to stop by. There are also other resources. I don't know if they're here tonight or not, but one of the very best resources, if I could just give one, would be the National Council on Alcohol and Drug Dependence in the Rochester area. Their website on the resources tab has a ton of really awesome resources, ncadd-ra.org. Thank you so much for your time.
All right, Dr. Mendoza and members of our panel, thank you so very much. We now have a few questions that members of the audience I know have shared with both you, Dr. Mendoza. I have a few back here. We will get to as many as we possibly can. So I would turn it over to, again, I think it looks like Dr. Mendoza, you've been vetting some of them because some of them are specific to some of our panel members. Perhaps we could read the first one and just get started, and again, see how many we can get through.
So I'll start with an easy one. Should people throw away or flush medications? Why is this dangerous? In the olden days, like 5 years ago, we used to tell people to flush their medications down the toilet. That's not really safe. We have better alternatives now. We have a number of, as Chief Henderson talked about, we have a number of safer ways to do that. The reality is that, the drugs, even though they're getting flushed, aren't necessarily out of the system. And if you're putting them in the trash, we know people who are going through the trash to find drugs. So do the safest thing. There's really no good reason not to anymore. Take it to your local sheriff substation or the town hall or health department, Wegmans, CVS. Many of the pharmacies are already taking back medications. I got a bunch of questions here from people who I know are doctors. Y'all don't talk like normal people. So the questions all revolve around what are the ERs doing to mitigate this crisis. I think it's safe to say, and I think my ER colleagues will agree with me, that treat and release is not working anymore. And that is the reason behind why I'm focusing on the ER, the emergency departments first. And truth be told, the health department, our role, my role in the ERs is relatively limited from a day-to-day standpoint. So I'm really using our position in the county to influence my colleagues in the ERs. But I've convened a number of conversations with the chairman of both the departments of ER at RRH and U of R. And quite frankly, they don't agree. There is yet to be agreement on what is the appropriate protocol to implement in the ER. So Narcan, we all agree, is important. Believe it or not, you can't dispense Narcan out of the ER. You can only dispense Narcan out of a pharmacy. And we all know that if people who come to the ER don't come during pharmacy hours. So I've got some informal commitment from both systems that we're going to look at trying to open up a version of a 24/7 pharmacy for Narcan. But that's going to take some time. So that's the most basic thing that we can do. More importantly, the colleagues in the ER are telling me that they are open to providing medication-assisted treatment in the ERs, but they're uncomfortable because they don't know where these individuals are going to go. And I think that's a valid argument. The reality is that the ER cannot be the solution to this crisis. The ERs are flooded already with so many things. And we can't simply rely on the ERs to do it all. As a family physician, as a primary care physician, I believe that primary care needs to step up and do our part to provide medication-assisted treatment. And to that extent, we've implemented a number of training programs for my colleagues to be able to provide Suboxone and buprenorphine in the community. What is the county doing to expand capacity for treatment beds? So you may have noticed the, I can't remember, $2.1 million dollar grant that was awarded to Villa of Hope. They will be expanding their detox bed capacity by 18. Unfortunately, we saw another institution is going to be moving their beds, so they're going to temporarily close down. Bottom line is that we don't have enough beds in this community. County Executive Sheldon Alpha was a part of, wrote a letter of support for Villa of Hope, and it's clearly not enough. I just got off the phone today with a number of people who we are in conversations about trying to look for other avenues for expanding capacity for detox beds. The reality is that, we can't just focus on detox beds, and I've said this before. If all we do is have detox beds, but we don't have a way to provide people with long-term recovery, then that's not going to be enough. We're simply going to get people out of the acute phase, but we need to have a way to keep them in the chronic recovery phase. So it's a very complicated pathway. And then there were a couple of questions regarding school access to Narcan. So from my standpoint, I'll leave this one up for the schools, but what I've been encouraging all the schools to do is to consider whether Narcan makes sense to have in your school, and I would argue that it does make sense. It is literally this. It's completely safe. So if you give this to somebody who is not in the middle of an overdose, nothing good, nothing bad, nothing at all will happen. And we know that this is covered by the Good Samaritan law. So if you as an individual were to use this on anybody else, you're completely safe from any personal liability. We've taken this to the restaurants, and a number of our restaurants have accepted the offer of having this available in their restaurant. What I've suggested to the business community is that if you've got an AED in your facility, you're already entertaining far more risk than having Narcan in your facility, because an AED can harm people if done incorrectly. This won't. So if you've got an AED, somebody's already accepted that the risk is negligible, or at least worth the benefit. So I'll leave it up to our colleagues at the school to decide whether they want this here. But truth be told, I think this is kind of a no-brainer from a safety standpoint.
Actually, I'm going to ask Lance or perhaps Carolyn, do you want to weigh in on that?
I was going to, we do have it in our middle school and high school. Our school nurses have been trained, and we do have that. And so we have not had to use that at this point, but we do have it available.
The statement was, why not in all the schools? I think it's a valid point, and it's something that we certainly need to be, take into consideration.
Another question here. What is the plan for the schools to teach students about the high probability of addiction occurring should they make the initial choice to try opioids? Well, just educational background about the whole pattern of substance abuse disorder, independency. That's taught right from the middle school time, just within our health education classes, and continues here at the high school itself. I know I've been a part of it, and I know the health educators have been changing as the field starts to change. There's different things that are continually occurring, new data. So getting rid of some of the other things, even some of the language that Lori was talking about, and introducing the students from TCMS, our middle school, all the way up to the high school. Now, in the area of just making the choice to try opioids, in our counseling department, we've already been dealing with this for a number of years. And not only working with the students, but working with their parents, guardians, whomever it is, because we intervene. We've got to give them the services that they need, and that's beyond just our high school or even our middle school if it's that. Again, wonderful service centers that are here tonight. They can speak on it a little bit more, what happens on their end, but we will walk the family from this point and the child to this agency, or in some of them we have relationships. They'll come here, and we'll have that conversation, and then we'll go from there. But that's again in the area of opioids. In some areas, we have seen some of this coming already in some ways. Again, it's not always the student. It's a parent or a very loved one that's within the home. Just like in some of our mental health areas, we have to really support them to understand what's going on in this whole recovery process or lack thereof, or needing treatment. So it's kind of it's a whole full picture here.
Were there other questions that were offered to the panel, potentially? I mean, I have a few back here, but I want to make sure we kind of are dividing and conquering here.
Go ahead.
Okay, so this is for Dr. Mendoza. Will the brain ever return to the total blue? And if so, how long?
I'm not aware of the studies. So the question is your brain completely back to the normal brain? I'm not aware of the studies to be sure, but I'm pretty sure it will not. Like I said, recovery is an illness. It's not a choice. You can't just wish it goes away. Now, after many, many years, perhaps, but our experience is that it takes, years, decades. And because the risk of relapse is so great, we don't want to assume that people can just kick the habit and move on. I think, we view addiction as a lifelong process to help to keep them out of it.
Okay. Another question asked, if you came across fentanyl while cleaning or using a bathroom, can you also experience an overdose or a reaction of some sort?
Chief, you want to take that one?
So the answer is yes. And, when the officers go in to do a search warrant and they think that they're seizing heroin, there's a good likelihood that they're seizing fentanyl. And they use, universal precautions. The officers use latex gloves, and we also not only carry Narcan to deploy to somebody in need in a crisis, we also have Narcan in the event that an officer were to experience the symptoms of an overdose. So I would say that if you came across a substance in a bathroom, that you contact somebody and it needs to be handled in a certain manner, not just to clean it up yourself.
Another question here, what is the school doing to have open conversations with students and parents when the first signs happen? Some of our issues are confidential. If a student is maybe struggling or whatever level that they're at in their involvement, these are things that we will have not only conversations with the family, but also provide education for the student. And it's usually not a one-time thing. We're going through really taking an assessment of how deep the issue is, and if we have to maybe involve outside services. And that's not in a punitive way. It's just certain things. Usually, sometimes when we see things in the school, there's some other things that are going on as well. But having a confidential conversation, sometimes just with the student, it leads to, we need some additional supports. And then we attempt to get the parent caught up in that, in the knowledge and understanding of the whole process. And that's where a lot of times outside services, facilities can really help us in that whole, that journey. Now, other areas, if something's happening with a number of our students or in our community, either building that we have in our middle school or in our high school, we'll tend to maybe talk about some of these things at our PTSA meetings. Just overall, I know I've done one recently myself on vaping or so at the middle school, and sometimes the times aren't the best. We try to do evening or we try to do it during the day. You just can't get everyone, and we get a decent turnout, but those are the times where we have some of these conversations a little bit more in detail on that. We're not trying to keep a lid on any of this information. Believe me, as I shared early from my piece here, the education, we want you to take this education and have this open dialogue at the kitchen table or wherever you may be, because if you're educated around these things, then you can begin to share with others. So this is not information that we really want to hold on to. And I know my colleagues in many other districts today, I had a meeting with them, and it's the same similar approach. We get the information and we get it out there, and then hopefully what you'll do is provide real information and not kind of mythical type of things. So again, it's not something we're ever trying to hold on to information, but if it's an area of confidentiality, we have to respect that, and we will uphold that.
how are non-English speaking communities being educated about opioid use? And then the next follow-up is Dr. Mendoza's presentation available in Spanish.
So I can provide it in Spanish if you give me another 20 minutes. In all seriousness, we have produced already, so the Deputy Commissioner of Public Health, her name is Dr. Marilena Velez de Brown. She is of Puerto Rican descent. She has produced, and I have produced, videos on Narcan training. We'll be releasing those hopefully within the next couple of months. Hers is in Spanish, and I got the English version. We've been both on Spanish radio. I struggled through Spanish for half an hour. I think it was okay, but we are doing the best we can. We have been in touch with RIT. We're about to produce an ASL version of some of our materials. Clearly there are way more languages than we can speak, but that's an area of further exploration for sure.
We have time for about one more question.
All right.
And then there'll be time afterwards to talk to the panel if we have further things you want to find out about. And there are some agencies outside in the hallway too that can help you.
So we do have a few more questions. So the last question is, are parents in any way legally liable for their children's taking and potentially ODing on drugs?
I'm not a lawyer, so.
Well, I'm definitely not a lawyer.
You want to answer it from a medical perspective, or?
Good Samaritan, or?
I don't know. I really don't want to weigh in. There's some lawyers in the crowd.
Well, judge too. You're the judge.
I forgot the judge.
I used to play a lawyer on TV, so.
Close enough.
And as a typical lawyer, answer, maybe. It really depends on the situation. I mean, you're not going to be responsible for your adult child's activities, whether you're going to be responsible for your non-adult child having access to the medications or the drugs that you have is an open question. My daughter, who's an assistant district attorney, the chief said she's a good district attorney, recently had a case dismissed involving a mother who left their child at the house and the child overdosed and died. So it's not a clear question, but you can be responsible for endangering the welfare of a child, and under more severe situations, you could probably be responsible for the child's death.
Okay, thank you. I want to thank everybody for coming and thank our panel for this really informative evening. And if you have further questions, please know that we'll be here for a little while, and there are agencies outside that can give you some more information. So thank you to everybody.
This has been a special presentation from the Brighton Central School District.